All right, I think we're live. Are we live? Are we counting down? All right. Well, I think everybody knows me, but I will introduce myself. I'm Matt Foltz. I've been doing orthopedics and sports medicine for over 30 years. I worked for a big healthcare company for 11 years, got tired of the way they were doing it and how they were running people through, and decided in February of '07 to start Champion. So I think most of you guys have been through the mill here. You know how we operate. Um, I started this longevity seminar because we see oftentimes people go like for example shoulders. People come in, they say, "Well, my shoulder started hurting 9 months ago, and I thought it'd get better." And then a couple months later, it got worse. I had to stop playing sports. I loved playing tennis or pickleball or golf or whatever, and it got worse, and I didn't do anything about it. And finally, it got to the point where it was way far gone, and we, possibly could have done something to at least hold off a little longer, play sports longer. We see the same thing with baseball players. This will be recorded, so we'll be sending this out to a lot of baseball players. Baseball players pitch, they don't tell their coach, and shoulders sore, but they don't tell their coach, they don't tell their parents because they don't want their parents to know. Next thing you know, they feel a pop. They're 16-year-old or 17-year-olds, probably had a future, and now they're sidelined. They don't pitch their senior year, and they're devastated. And we probably could have done something about it prior to that. So I'm thrilled today to have Dr. Ansari come here and speak. He is I call a shoulder guru when people ask. Um, he's been practicing with resurgence up in Cumming area since 2003. He went to the University of Cincinnati College of Medicine, where he got his medical degree. Emory University for his residency. I'm an Emory guy myself. Um, some of his accolades. He has been a team physician for the NCAA SEC Men's Basketball Championship, team physician for NCAA Division I Women's Basketball Tournament, team physician for NCAA National Wrestling Championship, also a team physician for WWE, what you see on Monday nights one time. That was fun. Um, the associate team physician for the Cincinnati Mighty Ducks of the American Hockey League, associate team physician for the University of Cincinnati, served as associate team physician for the NFL Cincinnati Bengals. He was awarded Best of Forsyth top physician in orthopedic surgery, honored as a top doctor in orthopedic surgery by Castle Connolly, and recognized as a top doctor in orthopedic surgery by the Atlantan, which I believe is a magazine, right? That's that magazine we see. Yeah. Mm-hmm. And so that's a pretty big honor there too. So Dr. Ansari is here to talk about shoulder dysfunction, shoulder surgeries, just the latest, greatest things that are out there. If y'all have questions, let me know. I'll pull the mic over to you guys so we can hear your question on the camera. And so, Doc, come tell us what's new.
I'm going to
Yeah,
try.
let's do it.
First, I want to thank Matt for inviting me. Matt is one of the first healthcare providers I've met in August 2003. Just finished my fellowship in arthroscopic knee and shoulder reconstruction back in July of 2003. Come here. There's a doctor I think we all know very well, Jim Morrow, his office was below my office when I first walked in, and for some reason you were hanging out with him. I think you guys used to hang out a lot for many years, and got introduced to Matt, and Matt was very helpful to me in getting to know the community, getting involved with the high schools in the area, getting acclimated to the healthcare community here. And I think for the last 23 years or so, we've been working together and helping people as best we can. So my specialty is knee and shoulder surgery. I don't do replacement surgery. I do more of the arthroscopic, minimally invasive surgeries. Over a lifetime, most people are going to have either knee or shoulder dysfunction. I tell people the body's a mechanical device, just like your car. We use it every day. The harder you drive your car, the more likely problems occur. But even through normal wear and tear, issues occur that need to be addressed. So I see people of all ages. I see people with all kinds of injuries, see athletes, see weekend warriors, see people of everyday life, because this is a common problem we see. Shoulder problems are probably the most common problems I treat. Most people will have a shoulder issue at some point in their life, not necessarily due to injury or trauma, but more likely due to maturity, and wear and tear. Um, some of the most common problems I treat in the shoulder are rotator cuff problems. Rotator cuff's a group of muscles that allow us to move and use our arms. We use it with daily life. We use it with sports and athletics. With our current culture and population and our longevity, more of us are involved in sports for a longer period of time than we ever have. There's a lot more opportunity. I think most of us are leading healthier lives than previous generations, and I think we all realize physical activity and physical health is very important, and more so now than probably ever before. Um, Rotator cuff problems can be due to injury, trauma. You fall, you injure your rotator cuff, it tears. But more than commonly, it's just micro trauma over the years. Rotator cuff is a very strong muscle, but it's a small muscle. It doesn't have a great blood supply. So the stresses we put over the rotator cuff does cause micro trauma through years of use and abuse, and it can become dysfunctional and tear. Early signs of shoulder problems or rotator cuff problems is usually pain. Pain at night is one of the most common things we see. It's going to radiate the shoulder pain anywhere from the top of the shoulder down to the elbow. That's just the nerve patterns of the rotator cuff. People are always like, "Well, you tell me it's my rotator cuff. You're saying it's up here, but I hurt here." That's just a referred pain pattern. Night pain is one of the most common presenting symptoms. I think any of us, if we don't get a good night's sleep, it affects our lives more than pain during the day. So many patients come in and says, I can tolerate it during the day, but I just can't get a good night's sleep. The initial treatment is always when you see one of us and you come with shoulder pain, we get x-rays to start. We do an exam to figure things out. We often have to do advanced imaging like MRIs. Our hope is we catch it early enough, at an early enough stage where MAT and physical therapy can solve your problem without intervention beyond that being needed or done. Most of the time, if you catch it early, if you modify your workouts, modify activities, learn the proper techniques to strengthen your rotator cuff, maintain those exercises long term, that's real important. I think one of the biggest problems people don't understand at times about physical therapy, and I think Matt could comment this as well. Physical therapy is a lifelong commitment. It's not like you go to therapy, it solves your problem, then you stop. The problem will recur. And I think one of the most common questions I ask patients when I see them for a similar problem, they come back, a year later and they had a right shoulder problem. I sent them to Matt. They got better. And they're like, well, my pain came back. The first question I ask them is, have you been doing the exercises that Matt taught you? They're like, oh, was I supposed to? And I'm like, it's a lifelong commitment. And that's just overall body health. Unfortunately, not all problems are solved by physical therapy in the shoulder. Then that's where other interventions come into play. There's injection treatments, and there's new injections now than there were when I first started in practice. Cortisone's been used for years as a treatment to decrease shoulder pain. Most studies have found it's a good short-term solution, um, you know, for acute pain relief, but rarely is it the long-term solution. I tell patients if I use cortisone and send them to physical therapy, think of cortisone as a catalyst to get you over the hump so that your pain is less, so Matt can do more with you. But cortisone rarely independently of therapy is going to solve your problem. And there have been some studies that have shown repetitive cortisone injections can lead to more likelihood of ending up in a surgical issue. A recent injection that's more common now in our practice, probably over the last 15 years, is something called PRP or platelet-rich plasma. That's where we draw your blood, spin it down in a little centrifuge, get growth factors from platelets in your blood, concentrate those growth factors, inject it into the shoulder to help partial tears heal. Rarely for full tears do they help. Partial tears still have a blood supply. Thus, there's many studies that have shown PRP through a single injection can help decrease pain, improve function, not independent of therapy. I always tell patients, any injection is always an adjunct to PT, never replaces it. But it does have safer side effect profile than cortisone and can help things heal. And then when all that fails, when Matt can't get you better, injections can't get you better, and you're miserable, and there's a surgical issue, that's where my treatment comes into play, and that's where we do surgery to fix it. Arthroscopic surgery, the term arthroscopic just really means minimally invasive, no big incisions, little poke holes. Outpatient procedure done at hospitals, but most commonly down at surgery centers. We reattach those tendons that are torn off the bone back to the bone, reinforce the strength of the tendon's attachment to decrease pain. Not a quick recovery, but predictable. Small tears, if you catch them early, have a very high healing rate, 90% or greater. Medium tears probably heal at an 80% rate, and large tears don't heal as predictably. So, what you want to do in any treatment of the shoulder, get it earlier. Your results are better and more predictable than if you catch it late. Um, Rotator cuff surgery's come a long way. When I was first in training, we used to have to slice you open. Now, with the minimally invasive techniques and the nerve blocks that we have, the recovery, at least the short term, is a lot better. Unfortunately, biology is biology. We still have to get the tendon to heal. It's still a long post-surgical recovery. People are always like, well, I'm a quick healer. I'm like, well, that's between you and God. Biology is biology. You still need to wear a sling for 6 weeks and protect it for 4 to 6 months. Debbie can comment on that. She's been through it personally. But again, I tell patients, if you have a personal relationship with God and he tells you your body's better than most people, then go ahead and accelerate your recovery. Other problems with the shoulder that I'll mention, I don't treat directly, is arthritis of the shoulder. That's where the cartilage is lost, the cushion between the ball and socket. Um, it's more common now than probably years ago, probably because we're living longer and we're more athletic for longer. But shoulder replacement is a procedure that's done for that, that also has a very high success rate. Partners of mine do that. I mainly focus on the minimally invasive arthroscopic surgery for it. Rarely does arthroscopic surgery help an arthritic shoulder. People are always like, can't you just go in there and shave my arthritis away? I could shave bone away, but then you have no bone in your shoulder, so that doesn't really help you very much. Questions? I mean, let me with the shoulder stuff. What kind of thoughts do people might have?
I got one.
Uh-oh.
Well, you mentioned about the wear and tear on the shoulder and the micro trauma over time and the falls that now create a macro trauma or a massive trauma. But I think, some of the things that which on your side, when you do a rotator cuff repair, is when people have a bone spur. And I think some people don't understand, like when you hear bone spur, like what's a bone spur? And I always, and then they don't. This may be prior to surgery. They'll say, well, they say I got a bone spur. I say, well, yeah. And sometimes a bone spur can be a big problem, or the way the acromion, which we can explain in a second, or Doc can explain what acromion is, kind of what they were born with.
So when we use the term bone spurs, there's two types of bone spurs in the shoulder. There's the ones Matt's referencing. That's the roof of the shoulder joint. So the shoulder consists of the ball, the socket, so it's your humeral head and glenoid. Above that is part of your shoulder blade. That's your acromion, and then there's your collarbone. All right. So between the roof of your shoulder and the ball, that's where the rotator cuff lies and sits. That's where it functions. When we say a bone spur causes impingement or compression against your rotator cuff, we're talking about development of calcium deposits on that roof that start impeding or occupying a space where your muscle sits, and that compression of that muscle against that occupying bone spur or calcium deposit creates friction, and that friction can predispose you to micro tears and full tears. So if that is part of the issue when we get to a surgical point, people are always like, you're going to shave away the bone spur, right? We always shave away the bone spur. We try to eliminate any mechanical irritation that will be a problem going down the road. But many times people say, well, I have a bone spur, don't you have to shave it away? If you don't have a tear or a micro tear or a low-grade tear, what a therapist can do is make that muscle stronger than a bone spur to make the bone spur less symptomatic. So a strong muscle is going to be able to counteract the effects of a bone spur than a weak muscle. So a lot of times, just because a bone spur is there, you don't have to shave it away. If we can get that muscle stronger than the bone spur and your symptoms go away and you maintain those exercises, you can live in a good spot.
There you go. All right, hang on. Let me bring my microphone back so we can hear the question. Oh,
it's like Jerry Springer.
Yeah.
Well, a little different.
What's your question?
No, my question is related to frozen shoulder. I'm experiencing it for the third time in my life. Now, the first time I was doing the military press and I had a crick in my neck, and I think that's what resulted in it. But the second and now the third time, I don't really know that I can relate it to a movement or some kind of injury, but someone suggested that it was a genetic component that I didn't know this, that only 5% of the population tend to experience frozen shoulder. So can you
I can
comment on
comment on
the?
that. Yeah, that's a really good one because I see a lot of frozen shoulder. So first of all, frozen shoulder is literally what it means. It's stiffness of the shoulder that results in loss of motion. Now, most frozen shoulders, unlike you, most of it's what we call idiopathic, without injury or trauma. Yeah, there are risk factors for frozen shoulder, and there's post-traumatic frozen shoulder. I was lifting a weight, I got an injury, inflammation sets up, lay down scar tissue, I can't move my shoulder. That's post-traumatic. That's the least common way to go frozen shoulder. Most people come in to see me and say, I've had the gradual onset of pain in my shoulder, and over the last several months, it's just gotten stiff. So the risk factors for frozen shoulder are several. Female, over the age of 40. And these are the highest risk factors. I'll get to other ones too. Peri or postmenopausal, diabetes, thyroid disease. So if you take the population overall, we see frozen shoulder more common in that subgroup. Men get it too. The most common risk factors for men are also age, dominant arm, diabetes, or thyroid disease. But most frozen shoulder is without trauma. But here's the good news about frozen shoulder. 98% of the time it gets better non-surgically through a combination of treatments to decrease inflammation, less so anti-inflammatories or injections, physical therapy, once the inflammatory, painful phase calms down, working on regaining motion. The frustrating part is it takes anywhere from 6 months to 2 years to get better sometimes. But if I try to tell patients that if you lived in Antarctica and did nothing, no access to healthcare, you're stuck on a research assignment for 2 years, you got frozen shoulder. If you did nothing, it would burn itself out, but it might take 2 years with no PT. The advantage of going to PT or doing treatments, you'll get better sooner. But it still can take a while. That's the hard part. For people are like, can't you just go in there and break up the scar tissue? I mean, you could do a closed manipulation, but I tell patients, work with Matt, work with your therapist. Slow and steady wins the race. You're not going to see sudden improvement. You'll see gradual improvement. It'll get better. And people are like, can't you just give me a shot? The shot's not going to cure your problem. You still have to go to PT. And I'm sure Matt has this discussion with people all the time. Is like, give me time, I'll get you better, but it's going to take time.
Yeah, when he says a closed manipulation, so if any of y'all know what that, I mean, that is they knock you out. Maybe even they might even give you a like a
Nerve block.
the nerve block, which makes the arm loosey goosey. They take it up, and it sounds like sticks breaking, and it's crack, 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 and then it's usually on a Monday, and they're coming here Monday, Tuesday, Wednesday, Thursday, Friday. We try to get a hold of them while the nerve block still kicks in, while we can still move them. But the problem with that is oftentimes is it starts getting tight again, and then so I usually take a picture of them. I raise their arm up, take a picture. Look what you can do, and have their husband or wife show them. You got there before. Let's work on it. But it can be a slow process, and it can be a very painful process. Hang on, you got another. Hang on, let me come back. That's all right. Go ahead.
I just visited my general doctor, and he was making sure that I didn't have any grinding. If you have grinding, is that like
That's
more serious?
So if you have grinding, that's a sign potentially of arthritis, and your frozen shoulder may just be an arthritic
Okay.
shoulder.
I don't have any grinding, but I was just curious because he asked that specific question. My follow-up question is: I tried to train to pickleball. In the very first game that I played, I developed pickleball elbow. Now, is that also a genetic component with?
Everyone I know gets tennis elbow or pickleball elbow at some point. It's a use and abuse thing. I've had tennis elbow multiple times. It's just the repetitive gripping activities, whether you're a plumber, surgeon, contractor, play sports, athletics that involve gripping, it's an overuse thing. I don't know the exact number, but at some point, I'd say most of us are going to have tennis elbow to some degree. But again, if you do the right isometric, icing, stretching, rest stuff, rarely does it end up being a surgical issue.
Now, I will tell you though, there are times where I guess now pickleball elbow is a thing, where pickleball elbow, if you do have a shoulder weakness, sometimes the overcompensation through the elbow to generate force. We see it a lot with more with tennis players because the racket's longer than a pickleball, and they'll tend to use more wrist action. And sometimes we'll talk to high-level tennis players like, oh, no, I don't compensate with my wrist until I have them start doing extra rotation. They start cocking the wrist back like this. So it tells me, well, you do have tennis elbow, but you also have some shoulder weakness that's contributing to that. So
I played tennis in high school, so I never had a twinge of tennis.
less likely when you're younger. It's an attritional wear thing. Yeah.
it goes along with that aging thing.
And the reason it was a problem way back when is those wooden rackets, the heavy wooden rackets. It was a game changer when they went to the graphite composite stuff. It's the weight of the rack. I mean, I remember having my dad's wooden racket in my hand, comparing it to my racket. It's dramatically different. The other thing about that Matt points out since we're on tennis elbow, compensating with hyperextension or flexion, weight trainer, weight lifters who hyperflex or extend when they're doing their final reps, it's real important to keep your wrists in neutral working out. That hyperflexion or extension when you're doing your workouts creates more stress across that, and I see that more commonly in that group too.
Yeah. Oh, here we go. We got a question in the back. You're next. All right.
So I do a lot of shoulder warm-ups before I do my chest workouts. Is there like one or two specific things I should completely avoid when warming up my rotator cuff? I do like a lot of like that. Inside,
are you doing it with
outside?
You doing it with the resistance bands or
with
just
a cable with like
cable?
5 pounds? Yeah.
No,
is there anything I should avoid?
No. How old are you?
24.
The fact that you're smart enough at 24 to know to do that stuff, you're way ahead of the game. Most people your age don't warm up, don't know how to warm up. I didn't. Just show up, change, and just start doing a bench press. So the fact that you're being proactive at your age, you're way ahead of the game. I don't know if Matt has any comments on that as well, but I mean you're ahead of it.
Okay, I was just wondering. I didn't know if there was one bad thing that you see online that you should do it or avoid it.
The thing where I tell people, and not at 20, you're 24, you can get away with a lot more than a 55-year-old. Lightweight, high repetitions as we get older is what we have to focus on. Like a person like me shouldn't. The thought of maxing out. I see guys my age who say, I was maxing out at 350 pounds, and I'm like, why? At a certain point, the mechanical. It's like your car. A brand new car is going to perform differently than a 55-year-old car. You can't put those same demands. So that's the hardest battle I find is where the analogy I always use, I go, no professional athlete retires because he wants to, and he has access to every medical care. So how can we think as just normal recreational people that we can expect the same thing as our bodies performance-wise as we did 15 or 20 years ago? You have to give into it. And when I say give in, that's probably not the right term. You have to modify so you can stay happy and not hurt. Because ultimately, the age game gets all of us. It's all about finding different ways to get our workouts in, to get those endorphins going, and still enjoy it without hurting ourselves.
Yeah, and like you said, the fact that you're already warming up is big. I wish we could get younger baseball players. I mean, we hear it. Oh yeah, they warm up. I say, well, they warm up. They go and we throw for 2 minutes, and then we get out in the field and we play. Well, probably throwing for 2 minutes is probably not enough warm up. And then they engage that, from 8 years old. 8 years old don't do any warm ups. Maybe, high five at each other. And then even the high school level, I don't think they really have I think some are better than others, but the ones that are serious aren't warming up enough before sports. Tennis players need to warm up before you start swinging the racket. Pickleball, it's softball. Swimmers, golfers, all that. But the fact that you're already doing it's good. All right, question here.
I came to physical therapy here for my neck.
Yeah.
And Jose gave me some exercises to do. One of them is I have my arms extended out and I lift them up and go down, and I do 30 repetitions of that. I'm at 9.5 pounds, which doesn't sound like very much, but I get a popping over here.
Does it hurt when it pops?
No. Is it something to be worried about?
No. Okay. So popping, if it's painful and it pops, then something to be concerned about. Popping, that's not painful. One could be just the way your body is, but two, our bodies as we get older are going to make more noise. As long as it's not painful, don't sweat it. I have patients come in all the time. They fill out your sheet. My knee, they say chief complaint, knee popping. And then they look at their pain scale 0. So the first thing I walk in there, I'm like, make it pop. And then I'm like, does it hurt? Nope, you're good. Like, I don't need an X-ray. I'm like, if it's not painful, I'm not going to get an X-ray to say you're good. So yeah, popping that's not painful, just accept as part of the aging process, as long as it's not painful.
Thank you.
Now, if it does start hurting, then jump on that.
Correct.
You either need to let Jose know, whether it's a year from now or whatever, or let us guide you where you need to go, and then we'll get you with Doc and say, okay, let's at least see what's going on, and then we can kind of let him or us monitor it and go from there. But yeah, I like the analogy of the older car.
Yeah, I use that all the time. I'm like, there's a warranty, and the warranty is going to wear out at some point. So,
Yeah,
and I think that's an important thing. Just we all have to realize is that God created this amazing mechanical device, and take care of it to keep its warranty extended, and that's key. You can't just take it for granted, right? You would never not if you expect your car to do well without regular maintenance, it won't, right? So our body can't be any different. You can't just say I'm going to live life without taking care of it. It's not going to hold up.
got to change the oil.
Got to change the oil.
Yep.
Rotors and brakes once in a while. Rotate tires.
Any other questions? Okay, here we go.
Yeah.
So my question is, I had surgery, shoulder rotator bicep, about 3 years ago.
Yeah.
I came here before surgery for 3 months to do PT. Then had surgery, came here for, I don't know, forever, a year, a long time. Anyway, I just can't even do this with weights, with little weights. Like if I
Painful?
it just doesn't do it. Like it doesn't want to. Not painful. Yeah, painful. I would say.
So have you had imaging since the surgery?
No.
So if you have a surgery and you have pain or weakness subsequent to it,
Weakness.
yeah. So if you feel weak, so here's the thing: the most predictable thing about rotator cuff surgery is elimination of pain. We always tell you the most predictable outcome from rotator cuff surgery is elimination of pain, night pain, and pain with use. Weakness is not always predictably recovered, and that's what all studies tell you. So part of it's also expectations. We want you to be pain-free and regain as much strength as possible, but you may not regain strength like you had it before it tore. Does that make sense?
Mm-hmm.
So, but at the same time, if you are looking, can anything be done beyond what I've done? Look at the integrity of repair, get an MRI, and then that test will allow the physician, the surgeon to say, oh yeah, there's a little weak spot. Let's just clean that up or reinforce it. Or this is as good as it's going to get. That's what you don't know without imaging.
Yeah, I think the part of that I don't know, I don't know if you all have had rotator cuff repair and Doc puts you in a little pillow. So you got to wear that little pillow. So, when you have a tear, the tendon is actually, it's torn, and he just can't take it and stitch it right back to the other tendon. I mean, there's going to be a change in tendon normal length. What God gave you is going to change a little bit. So, sometimes they'll, some larger tears, or maybe not even, it's going to essentially put you in that pillow to bring roll the head of the humerus back towards the tendon so it can heal better. But with that being said, even down the road, your body mechanics, the engine's changed a little bit. The functionality of your shoulders. Of course, in therapy, we try to retune it the best we can to say, okay, well, you have these 4 rotator cuff muscles that do a lot of stuff to the most flexible joint of the body to allow that ball to roll just right. Sometimes if it just is a little off, then it's not going to work exactly right, and it may be weak. So our best bet is to, try, like you said, maintain pain-free shoulder, but to try to get it as strong as you can and to get it functioning the right way again. Because that's the other thing. Most people, after a tear, they let it go along for a long time. They may let it tore. 2 years ago my shoulder hurt and they couldn't use it. Well, you've gone through a lot of shoulder dysfunction. I know you're in rehab for a long time, so yeah, maybe we need some further studies to see, okay, something else happened again. So
I don't know. I hurt, I go to the doctor.
there
And
you
then I
go.
come here.
There you go. Well,
Here's another good car. I love the car analogies. I'll use a car analogy again. It's kind of like, like you're in a car accident and your car's kind of busted up and you're waiting for the insurance company to say, we can repair it or get you a new one. You're like, oh, I hope I get a new one. The problem is we can't get a new one. All we can do is fix it. So even when you fix a broken car, it's better than it was when it was broke, but it's not going to be driving like it did when it was brand new. Once you have that injury, to Matt's point, it's never quite the same. Better than if you didn't fix it, but maybe not normal.
all right. We had a question. Here we go.
So I had early 70s, I was playing baseball, and I jammed my shoulder. I probably did something then, but it wasn't serious enough where it wasn't hanging. And I went another 15 years, and I moved down here. I'm playing tennis, and lo and behold, right up here, I hit the wrong. Well, I always had a thing where if I put a golf shot and I came over here, I paid for it twice.
Mm-hmm.
Bad shot, and this hurt.
Yeah.
And the same thing when I was playing tennis. All of a sudden, it was like this, not quite a tear, but it went from just hurting, and now it seriously detrimental to my game. I actually probably stopped playing tennis at that point. That was in the early 90s. I've never had it looked at, and I still, it's getting stronger as I did the rotator cuff 3 years ago
Yeah.
on the other side. But so I know that one was much more serious. This one's still getting there. I want to make sure that, what can I do? It doesn't sound like it's in need of any kind of tweaking, but some additional exercises
Yeah, I
might
mean,
help to.
if it's a nuisance pain, not a functionally limiting pain, I would start with PT and exercises and see if you can kind of tune it up that way. I don't know what, I tell patients for therapy to see the true benefit of therapy, it's minimum 6 weeks up to 3 months. If at 3 months it makes no difference, that's when typically I would say go see the doc and figure out what's going on. But it can take a 6 week. People are always like, "Well, I went to therapy for 2 weeks." I'm like, "Well, 2 weeks isn't enough to see if therapy is going to work." But if it's a nuisance pain and not a functional pain, I would start with therapy.
Yeah, and you said you fell on it years ago, right? Jammed it.
Early 70s. Yep.
Yeah. So you created some trauma then, most likely, but you were young enough, and then you just kind of your trauma has, yeah, the tires are balding a little bit, so you might be, hopefully not torn, but you probably have some tiny little tears.
Right.
That's getting your attention. So yeah, if it doesn't get better, then you got to go see doc. Yeah. You had a question, ma'am?
Yeah. Yes, sir. I wear a sensor. And so when you wear a sensor, you don't want to lay on it. You wear the sensor 15 days. Okay. So,
Where's the sensor physically located? On your arm?
yeah.
For diabetes?
Pre-diabetic.
Pre-diabetic.
So
Okay.
I'm trying not to be.
Yeah.
So I have to know the numbers and everything. Well, when you get up, your arm says to you, oh, you're going to lay on me? You're going to lay on me all night long because you only lay on one side.
Mm-hmm.
So when you get up, your arm hurts.
Right.
And I'm trying to figure out, I looked at different positions where you can put it so you can rotate.
The sensor.
Yeah.
Yeah.
So you can rotate it, but they don't have the accuracy. The accuracy of the number that you get, they tell you to put it right here on your arm. So the problem is, what do you do about that? I do isometrics, he taught me. So I lay in the bed and I use a cane. I use this arm strong, because you said it didn't have arthritis. And I slide this one up now, and that helps a little bit. And I put some, I forget the name
Do you
of the
change
stuff.
sides? Do you alternate sides?
Well, you get 15 days, and then you put the sensor on the other side. So yes. So, but you're laying on it for 15 days.
It sounds like you're doing everything you can. I don't
Yeah.
know that there's anything.
There
I mean,
is,
it's like
right.
nothing's for free in life. If I want the sensor, I'm going to deal with some shoulder pain, or if I want to improve my diabetes, or I don't want my shoulders to hurt, I'm just going to guess my diabetes and see if I can control it. So, I mean, I don't know that there's any perfect answer. I think you're doing everything right. If Matt's taught you stuff to do, just do that.
But you bring up a good point on side sleeping though, and shoulder pain.
Yes.
Some shoulder.
If you don't lay on your back.
There is some things that can occur from side sleeping, and how, I don't know if it's technically a blanching effect or what you would call it, where you're jamming the bursa and you're kind of
You're probably
Yeah.
micro vessels, compression. But I think most of us side sleep but can compensate. I think the best thing you can do is what you're doing already.
I use a special pillow
Okay.
so
There
my
you go.
neck doesn't hurt.
Yeah.
Can you sleep standing up? Is that a problem? That might help. If you do
Just
that,
don't sleep on your stomach. Me and
Yeah,
Matt
no.
don't like stomach
No.
sleepers.
you-
So I've got a torn labrum
Yeah.
that I'm living with. Had some good success here with some physical therapy to stop the pain and increase the mobility. You mentioned earlier about the PRP therapy. Can you expand a bit
Sure.
more about that? Because that's first I'd heard of that.
Yeah. So PRP, platelet-rich plasma, has probably been started in Germany probably 30 years ago. Kind of came to the U.S. athletic population in the 2010-ish, right? Doesn't that sound about right?
Yeah.
I think Tiger Woods and Kobe Bryant were the first guys that kind of broadened the spectrum for athletic use. So what PRP is, it's all of our platelets in our bodies are packed with growth factors. So what PRP is platelet-rich plasma. Draw your blood 30 to 60 cc's. There's a special centrifuge that spins the blood, and based on density of the platelets and growth factors, can separate out the packed growth factors in those platelets into a delivery device, basically a syringe. So this delivery device has all these concentrated growth factors. Then you inject the growth factor into a tendon, joint, muscle to help recovery. And there's now enough studies to say, one, it's definitely safe. It's literally by the time it comes out of your body, it's back in your body in 20 minutes. So it's safe. It can only help. Does it always help? For tennis elbow and partial thickness rotator cuff tears, somewhere between 60 and 80% success rate. For arthritic joints, to decrease pain from arthritic joints, probably an 80% success rate for up to 18 months. So it's effective. Now, 2010, when it first came out, it was not cheap. A single injection was between $5,000 and $8,000. But just like flat screen TVs, and prices have dropped, now you can get a single PRP for like $920, just because technology's mass produced and it's better, just like the TV. So we use PRP as a way to treat partial thickness cuff tears, chronic tennis elbow, pickleball elbow that doesn't respond to conservative treatment. We do it for arthritic knees to fight the pain from the arthritic, what they're called interleukins that are created by arthritis that cause pain. So one thing has to be clear though, with tendons, muscles, it can help healing. When I inject it into a knee for arthritis, people are like, am I growing cartilage or not growing cartilage? So for cartilage, which is very difficult to regenerate, PRP helps with pain. For muscle, tendon injuries can help with the healing. So for labrum, sorry.
That's what I was going to tell you.
Labrum, so labrum's kind of in between. Labrum's technically labrum's a ligament. So it's between cartilage and tendon. It's not quite avascular, but it's not purely vascular like a tendon muscle. So multiple studies on college baseball pitchers with slap tears have done PRP injections, and I have done it for a fair number of college athletes who are like, listen, I don't want to have surgery and miss the season. PRP can help. Single injection, I would say somewhere between 15% and 70% chance of improvement, maybe not elimination of pain. It's safe. It's worst cases, if it doesn't work, it just doesn't work other than the $920. So labrum's kind of in between. It's not as poor healing rate as cartilage, but not as good as a tendon or muscle group. But we do it for it.
Would they inject that right into the labrum? Or
Into the
would they
joint.
put it into the, okay.
So the labrum surrounds the shoulders, ball and socket, joint labrums around the socket. You go between the ball and socket, let it flood that whole area. It'll find itself to the labrum.
Insurance pay for this?
No, insurance doesn't pay for anything anymore.
No,
Yeah.
insurance doesn't pay. You can use now if you have an HSA or FSA, you can use those dollars, but insurance will not pay for it.
So that strengthened this muscle? It's not bothering me today, but you never know what's going to
I
happen.
would, before you do PRP, I'd get an image MRI just to make sure it's indicated. It could. It's more for pain improvement from injuries more than just strength.
Yeah, he beat me to the punch. That was the question I was going to ask. I came here because I was supposed to bring my 91-year-old mother who couldn't make it, but she's seeing someone within your staff here.
Yeah.
Does the PRP work effectively past? I mean, is there an age limit?
Great question. So that's a good point. So one thing about PRP, the health, so it's just like anything, we're getting it from your body, right? So intuitively, the healthier you are, your growth factors will be better than an unhealthy person. And the younger you are, your platelets probably have more potential for growth factors than age. So what they're actually looking at now, and some people are doing it, is what's called allograft PRP, where they only, so basically companies sell or thinking about selling PRP only from young people that are healthy, because the 91-year-old's PRP may not be enough to help her, but the 20-year-olds might. There's going to be additional cost to that. There shouldn't be blood typing because there's no red blood cells in there, so that shouldn't be an issue. But to answer your question, yes.
Okay. You mentioned that. What is the cost with PRP?
900. So they're all about the same, about $900. Between 900 and 950. Someone's charging you $3,000. So I don't know if Matt has a relationship with this company. There's a company on the radio a lot here in Atlanta.
I don't. So
All
I
right.
don't even know who you're
You know
talking
what I'm
about. Yeah, but no,
All
I
right.
don't.
QC
but-
Kinetics.
Okay.
I never received literature.
Well, they're on the radio all the time. QC Kinetics charges an exorbitant amount for PRP. It should cost you no more than for a single injection, $900 to $950. I've heard some patients go to QC Kinetics. They're like, "Yeah, I had 3 PRP shots. It cost me $9,000." I'm like, that should not cost that much.
So you got to go to a medical facility to get this.
You have to go to a doctor.
Yeah.
Well, that's what.
Yeah.
I mean, we do it at our office all the time. So my PA, Jason, does probably 10 or 15 PRPs a week.
So that was my question. Get the shot, bring it.
No.
They do
You
it
come
there.
to we do it right on site.
Oh, you come.
We have the machine there.
Oh, okay.
One of my staff draws your blood, sticks it in the machine, does all the work other than drawing the blood. The machine does everything, and then we inject it.
Yeah, and if you go for your knees or like both knees, sometimes you get like a little discount on the second one, right? Sometimes
There is a little bit, I think, because a little
like
bit.
50 cents.
Yeah,
No.
that might be generous. What's that?
Injections do you recommend, or was like average?
So I will tell you, most people, I say, try one, see what improvement you get. If you only get 50 to 70% improvement, it's probably worth doing a second. If you get no improvement, don't waste your money. If you're 80% or higher improved, don't waste your money. It's really only if you kind of get halfway where you want to be to do a second. And you want to do the second one about 3 months apart.
So you have doctors or offices you guys work with?
We do it.
No, they do it there.
Resurgence Orthopedics does it.
In fact,
let me make it clear. So my CEO corporate, Resurgence Orthopedics does PRP.
Yeah. And back when this first kind of started, I was a little bit of a guinea pig. Now I did a stem cell. I brought in, this is back when stem cells were a thing. And I was very fortunate that the company gave me a freebie.
Because that was expensive.
That was. Stem cells were really expensive. And a doctor in Ansari would text me about once a month. Hey,
are you better?
Are you $5,000 better yet?
Yeah.
And I'm like, I'm about $100 better. And then finally I got to the point where like, you know what? I think I'm probably $2,000 better, but I'm not. But that was with stem cells. And I did do PRPs. And I thought, you know what? That did work. But mine was on my knees with arthritis. So I'm kind of like.
And the stem cells he's talking about was from the placenta.
Yeah, that was placenta stem cells, which they kind of did away with all that.
Yeah, so the government came down hard on that.
Yeah.
Because indications work out there.
Yeah, and so now
PRP is FDA approved. It's like anything. United Health, your insurance company wants to take your money and not give it back.
Yeah.
It's totally. And if you look at recovery for professional, like in the off season, name the sport, hockey, basketball, PRP is used as a recovery method in addition to PT in the off season for guys with tendinitis and chronic injuries to help them just recover quicker. So it's been around a long time. And Germany did a ton of studies years ago on it.
All right.
One quick question. Cold therapy, is cold immersion therapy, is that a gimmick, or do you think there's some?
You're talking about the polar plunges and cold plunges?
Cryo plunge and.
I mean, it wakes me up. I've tried it a couple times. I think it, gets your endorphins going. Does the theory behind, the cell stimulation and healing and the mitochondrial effect happen? There's studies that go either way on it. I don't think it hurts.
Okay.
Now, cold therapy in general is in the acute phase is helpful, but if you're saying does the cold plunge I do 3 times a week going to change my metabolism? I mean, I don't know. There's enough studies to know that. The problem with a lot of that stuff is until you have a double-blinded placebo-controlled study, which no one's going to do, because the cold plunge manufacturers aren't FDA regulated, and they're like, well, we don't want to study. We can sell this stuff anyways. What if the study says it doesn't make a difference? No one's going to fund it. Because one, insurance will never cover it. You're going to pay out of pocket. And the cold plunge people's marketing is like, we don't need to prove it. People like it.
All right,
So you'll never know.
a couple more questions.
So PRP does not work for bone on bone?
Now, if you have complete collapse of your joint space, any injections decreases their risk of improvement. Yeah, I mean, I actually try to discourage most patients unless they're completely have no medical ability to pursue other options, meaning they're too sick to do something that I feel guilty. I'm like, well, you have bone on bone. I can inject anything in there, but I don't think this is going to help you. So if you have no space, like in the knee between your femur and tibia, I think you're just giving away money in that case.
One last question.
One last question. I went to your partner for knees, bone on bone. I had regenerative stem cells in both knees. So
Was it the placental?
the umbilical cord.
Yeah, same. Yeah.
So it took, if people would say, I think he asked me, did it work? I can tell you, I think it takes a long time for the girls to grow. I have no pain in either one of these knees.
That's good.
I wouldn't be walking. Where the
How
pain
long ago
went,
was your injections?
so let's see, maybe 6 years ago.
Wow.
That's good.
Emory bought them for me. So my daughter works for Emory, and I can't remember the name of the doctor. So they charged me $2,000.
It was Resurgence or was it somewhere? I mean, probably wasn't Resurgence, was it?
I went to his partner, and he's the one that told me.
Yarborough? You go to Yarborough or?
Yeah, I went to Yarborough. He told me I had bone on bone. So I did some research. And then I went to a meeting. They were charging $10,000 per knee, right? So I told my daughter, and she found this doctor. I think he takes care of the football players. Can't remember.
What's his name?
Dr. X?
I gave you.
X, I don't think does that.
I can't remember. But anyways,
Well, it's Kyle
he
Hammond
put
who
it
takes
in
care of
both
the
knees.
Falcons now.
And I also get the shots every 6 months, but I don't need them every 6 months. I might
So
go.
let me ask you this then: if you're pain free from, I'm going to be devil's advocate. If you're pain free from the umbilical placental stem cells, why do you get the other shots?
Because the doctor that gave those to me told me to continue because I
So
asked
what
him.
you don't know then is what you're benefiting from. If you have
Oh.
two things going into your knee, you don't know.
I never thought of that.
Yeah. So if the doctor who gave, so here's my thoughts on that, because it's really expensive to do what you did, right?
5,000.
Yeah. So if you have true efficacy from an injection, you shouldn't need any other injections. They shouldn't say you need this plus this, because hyaluronic acid does help the lubrication shots. If you're having those in conjunction with the stem cells that you got, it'd be hard to parse out which is really helping you.
So it could be the shot.
It could be the lubrication shots. Yeah.
But you know what? You're still going strong.
As long as you don't hurt, who cares?
Yeah, you don't. Yeah, you're a rock star. You're still moving
Yeah.
and going.
It's all the weight you need.
Be thankful. I want to let Doc go now. He's been very gracious with his time, and he's an awesome fella. Great, father, husband, and dog owner.
Yeah.
Right.
2 dogs.
2 dogs.
Big dog finally. Though. Real dog. Real dog.
But I think the takeaway message is, it's important to keep moving. And we already had a knee and hip one, and that's important. But shoulders can also sideline you, where you don't feel good. My shoulder hurts. I'm just gonna lay on the couch. I'm not gonna do anything. I'm not gonna get on the bicycle. I'm not gonna do this, that, and the other. And movement longevity is important. Like I said, endorphins, all the things that make us feel better. And that's the whole point of this. You guys that are here today, we're going to use you as a sounding board. You hear your neighbor or somebody say, yeah, my shoulder or whatever, my knee, go get it seen about. Tell them, you know what, don't lollygag around. Let's move forward. And let's not, because I tell you what, outside of doing nothing doesn't help anything. You gotta choose the higher road and start doing something about it. So
agreed.
Any last thoughts?
I think it's well said. Just be proactive about your health. Take care of your mechanical body as you do your heart, lungs, and mental, and just be proactive. I think that's the biggest thing.
All right. Thank you guys for coming out.
Thanks.
Yeah.
Appreciate it.
Yeah. Hey, let's do a little fist pump.
All right,
Bam.
man. We got it? Oh,
Yeah, we're good. We're good.